Okay, so this is Dr. Karen Bowen, Director of Medical Bariatrics at Novant Health. So my goals for the interview are basically just to learn about what a director does, especially in bariatrics, and I guess just like your job all around at the office, at the hospital, and everything that led you where you are at your job today.
Sure.
So I guess we can just start with we'll start at the beginning with your school and stuff like that. So the first two questions just are dealing with like your education and like your majors and like stuff like that, if you want to
Sure.
go into it.
So yes, after high school, I went to undergrad, and I was a Bachelor of Science degree. My major was biology. So it was 4 years of undergrad, and then I took the MCAT to get into medical school. And then I did an osteopathic medical school, which was 4 years. And then when I graduated from medical school, I went into family practice residency, which I did at Moses Cone, which was 3 years. And then after I practiced for 6 years in family practice, I decided I wanted to go into bariatrics. So I took the obesity medicine board. So I have active board certification in family practice and obesity medicine.
Okay, so there's different, you have to be different or certified if you want to go into bariatrics too.
So right, anybody who is board certified in obesity medicine has to have either internal medicine, pediatrics. You have to have family practice, something as a first before you can go into obesity medicine.
Okay, where did you go for undergraduate and medical school?
Sure. For undergrad, I went to a little Catholic college in Florida called St. Leo. And for, what did you ask, medical school? I went to the osteopathic school in Des Moines, Iowa.
Okay. Do you have any or do you want to talk about like your like I guess like path through medical school, like that because you went into family practice first?
Sure. So, I mean, in medical school, I think allopathic and osteopathic medical schools are very similar as far as the setup goes. Your first 2 years are didactic, so you're in a classroom, studying a lot, taking tests, doing anatomy lab. That's pretty much the same across the board for allopathic and osteopathic medical schools. And then your third and fourth year, you're out doing rotations. And so you rotate through different things like family practice, surgery, neurology, all that stuff. So you're spending like each month is a little bit different.
Okay, yeah. So you said your residency was only 3 years, right? So can you like talk about kind of what you did during that time?
Sure. So residency is sort of like all of a sudden you're a doctor, you graduate from med school, you're out there working in the hospital and in the clinic. So for family practice, it was a bit of a split. A lot of it was hospital, some of it was clinic for family practice. And so you're working. Back when I did residency, I know there's work hour rules now, but we worked 80 hours a week. We were on call every third or fourth nights, and on call meant you were sleeping at the hospital, admitting patients, working underneath attending physicians. So you would rotate through different things. Even though it's family practice, you still had to do nephrology and neurology and surgery and everything, as well as doing your clinic time in family practice. So yeah, it's a lot.
Yeah. So once you graduate medical school, so you basically like what made you decide at first to do family practice?
So that's a good question. I remember in med school, my third and fourth year, when I was going around and doing my rotations, I really had no idea what I wanted to do. And I figure, well, something will jump out to me that I'll like, right? Yeah. And so for me, it was more like a process of elimination. Like, a lot of my friends went into like anesthesiology, but every time I was in the OR, I was so freezing cold. I was like, I cannot be in the OR. Like, I'm just so cold in here. I just can't do it. And then surgery, you're standing all day. It would kill my back.
Yeah.
And I don't know, I just like, I would rule out certain things. Like I really felt like peds, I just didn't have the patience to deal with kids all day.
Yeah.
And family practice was a little bit of a mismatch of everything. So I get bored easily doing the same thing. And I kind of like the idea of having different things I could see throughout the day doing family practices. Kind of initially why I went into family practice, is to not get too bored.
Yeah. Was there like a close second besides family practice, or was that like really the only one?
Mm, yeah, I think my second was like physical medicine and rehab. And that's just because I liked sports and, more of the physical medicine than anything else.
Would you say that residency or medical school was harder?
Oh, definitely. Well, I say residency was more grueling. Medical school was definitely more like classroom hard, and residency was more like working hard, hours hard, lack of sleep hard.
Mhm. Yeah. Do you like, how difficult would you say the transition is from like undergraduate to medical school?
It's hard. I remember, because I mean, college, I studied a lot in college to get good grades and to get into med school. Um, but I'll say, like, I don't know, I took a lot of AP classes in high school, so I kind of felt like college wasn't as hard as everybody said it was going to be. Like,
Right.
I had a few hard classes. Like, I remember organic chemistry being hard, but like, and physics being a little hard, but I don't really remember it being like super, super hard. I mean, I could get A's without too much work. But then I remember getting into medical school, and we were in our first year classes, and one of the professors was like, look around you, everybody else graduated in the top 10 of their class too. So
Yeah. That is true.
so it's like, okay, well, you're in with a bunch of smart people.
Yeah, it's like even higher level. Yeah, that's true.
Yeah. So
Okay.
it definitely took more work. It was more work than I think I knew it was going to be,
Right.
but I did it
Okay.
anyway.
You succeeded. So what is like the main differences between like having an MD and then having a DO?
Right. So a lot of people, and especially in the South, a lot of people still don't know what a DO is, which is kind of frustrating, since I went to osteopathic school in the Midwest where there's a lot of DOs, but I feel like in the South, I always have to explain what a DO is. And, it's still going to medical school. It's the same grueling classwork. Um, some of the differences are, in DO school, you have to take an extra class called osteopathic manipulation. So you learn a lot about like assessing a spine and doing, different types of things to help relieve musculoskeletal pain. So it's like a lab and a class, and you learn about how everything's interconnected.
Yeah.
So there's the OMT part, and then there's also the part where in your third and fourth year in DO school is more in tune with primary care versus like things that are super subspecialty, like neurosurgery or something like that. So you have to do more primary care rotations than allopathic medical school does.
Okay.
And since I didn't really know what I wanted to do, it kind of fell in line with, I mean, I didn't really have a problem doing extra primary care.
Mhm.
But then, so the big difference, so when I graduated from osteopathic medical school, and then I wanted to go, you have to rank where you want to go for residency. And I liked Moses Cone, which was an allopathic residency program. So I didn't go to an osteopathic residency. And so in turn, what happened was I went into an allopathic residency, which you can do as a DO. You can go into an allopathic program. Is I'm board certified under the MD boards, not the DO boards.
Oh, okay.
So yeah, because I did an allopathic residency. Yeah.
Okay, that makes sense. So you're board certified as one, but you're like technically
I know. So like nobody knows that, because nobody looks that my board certification is the ABFM, not the ABOFM. So, I mean,
yeah.
the tests are equally hard. It's just
Yeah.
different,
Yeah. That's interesting.
Yeah.
I didn't know. Yeah.
Yeah.
I always wondered because I know like my dad's an MD, but like I was just like I
Mhm.
would always wonder, and like now that makes sense.
Yeah.
Okay.
Yeah.
So we talked about family practice. Okay, so what made you change to bariatrics?
So that's a good question. So when I was doing family practice, I think a lot of it was I didn't really know what it was going to be like, getting out of residency and then going into a real job, like what my day to day was going to be. And um, I don't know. I think that I was just naive going in, that I thought I could help everybody. And in turn, I was, seeing a lot of people that just kind of didn't really want to help themselves. And I just felt like I was, treating people's like diabetes, but they weren't really changing their lifestyle. And so all I was doing was like adding medication.
Mhm.
And you can, kind of felt like you're a hamster on a wheel, just kind of
Yeah.
not really helping people. Like I really wanted to help people, and I really didn't feel like I was getting that satisfaction back. And so probably about 5 years into family practice, again, I got bored again, which is really bad when I get bored, because then I start thinking, okay,
Yeah.
what else can I do that I'm not going to get bored, that I'm going to like better.
Mhm.
And so I just did a little research on my own, and I always liked like nutrition and exercise. And so I stumbled upon the Obesity Medicine Association. And I had to do CME anyway, which is continuing medical education. So for family practice, I went to a Obesity Medicine Association CME conference. And I had done plenty of these for family practice before. And usually I'm bored sitting through lectures about high cholesterol and hypertension. But when I went to the obesity medicine one, I was just like the whole time I really liked it. I sat through every lecture, and I wasn't bored at all. And I was like, oh my gosh, I really, really like this. I want to learn more. So I just sort of on my own realize, okay, I'm going to do like another obesity medicine conference. I'm going to do more CME for this and see if I want to sit for the boards. And so it did take me a couple years to reach my CME for obesity medicine and then sit for the obesity medicine boards, because you have to do certain things to sit for the board exam.
Okay.
But yeah, I lucked out, because once I took the obesity medicine boards and passed, this job offer came to me from Novant, and it just so happened we were starting bariatrics, and
Yeah.
sort of it all worked out.
Right. Yeah. That's cool.
Yeah.
Okay. So now we're at bariatrics.
Hmm.
So what does your typical day look like on the job?
Yeah. So I mean, I'm outpatient only, so I don't do any inpatient. I have clinic patients now. With since the pandemic, I'm doing kind of a mixture of video visits and clinic patients. So before March, I would tell you I'm seeing clinic patients
Mm-hmm.
from 8 to 4, Monday through Friday. But yeah, right now it's sort of a mixed bag. It's some visits done via video, and the rest are all clinic patients coming in.
Okay. So what's
Mhm.
um like in your day, like how does a visit like go? Like, you know what I mean? Like how do you like take your patient and like what like do you go through with them kind of?
Yeah, so I mean, there's new patients and then there's follow up patients. So, new patients, I actually created our new patient assessment, and it's kind of based on what the obesity medicine standard is. And it's really looking at all the facets that lead to obesity, right? So, I mean, some people have genetic predisposition, some people it's more environmental. We ask about how active a person is, who else lives at home with them, what their weight history is. So, like, did they more recently gain weight? Have they been up and down their whole life? Have they been overweight since they're a child? And then we ask about their lifestyle. Are they eating every meal out? Do they meal skip? Do they crave soda and sweet tea? So we get a whole assessment about kind of the things that lead into a person's weight problem, because it's not one size fits all. It's very complicated. And then you've also got like, do they have depression? Do they have substance abuse? Because if you're dealing with some of those things or eating disorders, it's a lot more complicated.
Mhm. Yeah.
So
So
for a new patient,
yeah.
we're like doing that. So we're looking at what's leading to their problem. And then we're looking at labs and really looking at, okay, have we identified anything in this patient's um, problem list, or do we find things that are weight related? So we're really playing investigator, which I really like that about
Yeah.
obesity medicine. Is a lot of times we're looking at labs and we realize, oh, you know what, this person's had elevated liver enzymes for 3 years and nobody's ever looked for fatty liver disease. So
Mhm.
we order the liver ultrasound, and lo and behold, they have fatty liver disease. So I
Yeah.
mean, they never knew that.
Mhm.
Or we diagnose people with diabetes because they've never had an A1C done before. So I mean, we're identifying things that are weight related and then giving that information to the patient. So instead of just saying, you need to lose weight, it's
Yeah.
saying, gosh, you're pre-diabetic or you're diabetic, and look, you have fatty liver disease and you have sleep apnea. All these things are weight related. So it's not just lose weight, it's you need to lose weight because now your health is really poor
Yeah.
because of all these things. So
Yeah. That makes sense. So,
yeah.
so I know you said outpatient. So do you like see people, can you see people like after they've had weight loss surgery, or do you only see them like before, like if they need weight loss surgery and stuff like that? Like,
Right. So I do see people post-op, but the post-op care I do is for mostly post-op malabsorption. So people that have, iron deficiency and B12 deficiency, we help manage that. And we also see quite a few patients for post-op regain. So people that have kind of fallen off track,
okay.
we see them back. Yeah.
Okay, that makes sense. Um, okay, so what would be your favorite part about your job?
Well, I will say, making the switch to obesity medicine was very rewarding for me because I just, when I was doing family practice, I just wasn't feeling very rewarded when I would come home. And the most rewarding thing is when I make a difference in somebody's life and they're very thankful for it. And so I get to see that almost on a daily basis, is that somebody's actually happy
Mhm.
about the changes they've been able to make. And so, a big part of my job is just teaching people, which I never thought a doctor did teaching, but I do a lot of teaching now.
Yeah, definitely. What would be your least favorite part if you had to say?
Yeah, definitely dealing with different personalities. And so that's definitely something I wasn't ready for, is dealing with like mean people that are just mean, and people that want something for nothing. It's just frustrating because, you go into medicine to really help people, and some people don't want to help themselves, and some people just have psychiatric problems and they're going to take it out on you no matter what. And I think that is just a hard thing to try to
Yeah,
learn how to deal with.
yeah, definitely. So is there like, um, I'm trying to think of how to word this. Is there like a common type of like patient you see? Like, is there like some cases you see more often, like diabetic or like something like that?
Yeah, I mean, we probably see diabetes and pre-diabetes more than anything else.
Okay, yeah, I didn't know if there was like
Yeah.
like a most common, I guess, but you said there was like all these different ones, so I was like, that doesn't really make sense.
Yeah, yeah.
Yeah, so how do you like tell if like your like treatment plan and that kind of stuff is like successful?
Right. So that's the importance of follow-up. So our follow-up visits, we're assessing each time, and typically we see patients back about every 2 months, but um, they are also seeing, a lot of times they're seeing our dietitian as well. So they'll like see me and see the dietitian the next month and then see me the next month. So about every month they're seeing somebody usually. And so we're gauging their progress, right? So that's kind of the cool part about bariatrics, is there's always supposed to be forward progress. And
Mhm.
if there's not forward progress, we can have that conversation to be like, hey, this isn't working. And whether we pass the baton to somebody else,
Right.
or we say, hey, you need surgery, or we say, okay, this ain't working, you're not ready yet, go back to your primary care. That's kind of the nice part with
Mhm.
my job, is I'm not stuck seeing them forever like I was with family practice.
Right.
So
Yeah, that's yeah, that sounds good.
yeah.
Hmm. is there like how like what percent or like roughly like patients do you think like don't follow like the plan and like end up having to like come back and stuff?
Yeah, I mean, I would say there's probably about maybe a quarter of patients that, don't really do what they're supposed to do. Now, I'll say sometimes it's about timing. So let's say there's a quarter of patients that don't lose the weight or don't make the lifestyle changes. A lot of times it's, I'd say there are those people that want something for nothing and they're not going to see progress. And then you've got people that I just call it bad timing, like people who are in school and working 2 jobs and they expect to lose weight and they got no time to exercise. So like, or they're depressed or they're in a bad marriage. Like there's a lot of things that kind of have to, it's complicated. There's a lot of factors that are involved. And what I'll tell a patient if they're not really seeing the results they want to see is, we'll go through some of these barriers. And if they say, gosh, I'm working 2 jobs and, I'm in school, I say, wait till you're done with school and then come back, right? People put so much pressure on themselves.
Right.
And if you catch them on a better time, they'll do a lot better.
Okay.
So, yeah.
So, I just lost my question. I'm talking about, okay. Oh, okay. Is there a certain like criteria like people have to come see you? Like do they have to be like at a certain like weight to like see you? Like
Yeah. So we see kids that are obese. So we see childhood obesity, teenagers, and adults. And so based on body mass index,
okay,
it's
yeah, I was wondering if there was like
BMI of 30 and over, which is, class 1 obesity and over.
Okay. Yeah, I didn't know. Oh, so you can see people as young or as old basically depending on or if they
Yeah.
max that weight or whatever.
Yeah.
Okay, that makes sense.
Mhm.
Okay, how many hours do you work on a normal week?
So I'm actually I'm contracted for 36 clinical hours. So yeah, that's my clinic time.
Yeah.
So
Okay.
yeah.
That makes sense. So I know you talked about like the weight loss side kind of. So what is like the kind of like nutritional part of your side, I guess, or part of your job, I guess?
So, and that's hard because
Yeah.
since we do have dietitians in our office, I
Right.
try not to play the role of the dietitian because that's not my licensing. But
Okay.
we also have like patients that don't have insurance coverage for nutrition. And so those are the folks that, I probably do a lot more teaching on their part. But I'll say almost everybody I see, I counsel them about reducing sugar intake, how to read a label for sugar, how to do basic dietary logging, like using some of the apps out there.
Mhm.
And then just kind of tweaking people's behavior, right? Like so many people just have bad habits of like skipping every meal and then they eat a huge dinner and then they snack until like midnight. And that's just like so bad for you. So,
Yeah.
I try really to start making some changes there. I'll give people like lists, but it's not cookie cutter. I really kind of look at a person's personal story and then try to make some little changes based on what they tell me.
Okay. How do you like determine like I guess is it just like different with every patient with like if like the severity, not severity, but like the treatment in terms of like if they need surgery, like if they just need like a special diet or stuff like that?
Yeah, well, I mean, first based on body mass index, if somebody's body mass index is over 40, we always say, hey, you qualify for bariatric surgery. I mean, I do. So that's one of the things I do. So if their BMI is over 35 and they're diabetic or they have sleep apnea, I always throw it out there as this is an option for you because a lot of people don't realize it's an option, right? They say, oh, I thought I had to be 600 pounds to have surgery. And I'm like, no,
Yeah.
you actually qualify. So it's throwing it out there. That way people know that it's an option. And then a lot of times I feel like people have already decided before they walk in the door which avenue they want to go down. Some people are just adamant about, I don't want surgery. And, the frustrating part in the back of your mind is some of these people are like, but you really need surgery.
Yeah.
So it's, how do you approach that in a way that's not pushy?
Right.
But one thing I have learned to do, it's sort of an art of like how to have these conversations
Yeah.
is, to say, gosh, okay, we'll start on the other pathway. And, if they're a candidate for medications, try that, work on lifestyle change. And that's, again, the importance of the follow-up. Because if you see them back and they're not making progress, I go back to my first conversation and say, hey, maybe this
Right.
isn't working. Let's consider this. And, it's funny because I call it the boomerang effect, because people will come back a year, 2 years, 3 years later, and they'll say, I had time to think about it. I think I want to do surgery.
Yeah. Yeah. Is it
So
hard to like have those like conversations, like when someone's like not following like anything you say and then they come
yeah. And again, I feel like people put so much blame on themselves already. So it's not really up to me to ever yell at somebody. I never
right.
yell at a patient, because I tell them, I'm sure you beat yourself up enough already.
Mhm.
And most people have, but again, you're not going to get something for nothing. So if you expect to lose weight and you make no changes, it's
Right.
not going to happen. So, that's the hard part. And the hard part for me is when people say that, they only eat celery and they exercise an hour a day and they gain 30 pounds. Or that's the hard part, is I can't help somebody who's not honest with me. So
Right, right,
yeah.
right. Yeah, do you find like, or do you can tell when like a patient is like lying, and because right?
Yeah. And I mean, that's kind of the investigator part of my job, is like, I can look at somebody's labs and see if they're lying. I can
Yeah.
look if their triglycerides are high, they're either eating sweets or fried foods. So
Yeah, yeah, that makes sense.
yeah.
Okay, so I guess my last question would be, would you recommend your career to someone else and why?
So, I mean, there's so many things you can do in medicine. I think you got to like what you do. And I like what I do now. And I'm glad that I kind of made the switch. I mean, I can't tell you, if I was still doing family practice, I'd be super happy about what I was doing. But again, I think you got to find your niche of what makes you happy.
Mhm.
But I think going in the field of medicine, you do have to like it, because it's so much work and it's so much money, and it takes a long time to pay loans off, so you got to really like it.
Yeah,
And it's more studying than other people that go into other professions. It's like so much more work, and
right,
I kind of feel like doctors maybe don't get credit. Like, I don't know, I just feel like
right.
the healthcare industry has changed so much, and that's kind of the negatives are, is you're working for healthcare administrators, and doctors don't really have a lot of the power that they used to back in the day.
Hmm.
And then being a female in medicine is also different. It's a bit challenging. I'll say it's still a very male dominated profession.
Right. Okay, that makes sense.
Yeah.
I think you answered all my questions. I definitely know your profession now. I was a little,
Yeah.
I don't know, I was just like a little confused before. I was like, well, I know
Yeah.
she's a nutrition, but she's a director and it's bariatrics and blah, blah, blah. I was
So
like,
I didn't tell you what I didn't tell you. You asked me about being the director. So
oh yeah.
being the director basically just means that I am involved with like program development for medical bariatrics. So every time our program like grows or makes changes, I have involvement in that.
Okay.
Um, and I also supervise our PA and our nurse practitioners. And part of that is co-signing charts, it's education, it's, making sure everybody stays in line. And so that's kind of the other role, is doing that. So in
Yeah,
addition to clinic time, it's all
it's
like
that
the
too.
extra
Okay.
stuff. Yeah.
So so there are like people that do what you do but aren't a director too.
Um, in our program, it's just me.
Okay.
Yeah.
That makes sense. Okay.
Yeah.
Hmm. Nice. Okay, I
Mhm.
think that's everything. I definitely
All
know
right.
all about your job now and stuff.
All right. Well,
Um,
thank you.
but thing I just need from you is we have to fill out this you have to fill out this evaluation form, but I'll send you the link for that. It's
Okay.
it should be super quick, but that's the last thing I need from you. And
All
then
right.
you were my last interview too, so now I'm all done with my project.
Yay.
So thank you so much for
All right, no
talking to
problem.
me today. Yeah, I
All
really
right.
appreciate it.
All
But
right.
thank you so much, and
All right, no problem.
bye.